Hello everyone, thank you so much for all your love on the previous videos. So I'll just start with introducing myself. I am an IMG and I matched to family medicine in Ontario this year, and I'll be starting my residency soon. The purpose of making this video is to help you guys navigate through the pathway to get match. And so far, I have been making videos on my CALMS process and educational content, but I am soon going to start one-on-one consultation. So if any one of you is interested, you can just comment down below and I'll reach out to you guys on how we can schedule a one-on-one consultation in which I'll be helping with CV, personal statements, exams, NACOSCI, and QE1 all together. So yeah, you can utilize this time and just comment down below if you want. And today we are going to cover pharmacotherapy, antipsychotics. Specifically, this is the most important chapter for QE1 for overall in your general practice as well. My reason for making these videos is to help you guys navigate through QE1 challenges, NACOSCI, and the entire CALMS process. But even for me, it is helpful in clinical practices that if I teach you guys, it make me reminds me of all the information that I have learned in the past as well. So let's recall everything that we have studied, and throughout the video, I'm going to guide you regarding QE1 as well. What are the important points for QE1 that you need to really learn? Okay, so let's start. Antipsychotics used to be called neuroleptics. Overall mechanism of action is functionally analogous to varying degrees due to activity in target brain pathways, primarily indicated for psychotic symptoms like in schizophrenia related disorders, manic episodes, depressive episodes, substance use, medical conditions like neoplasms, treatment resistant MDD, severe generalized anxiety disorder, complex PTSD, severe OCD, borderline PD, behavioral symptoms of dementia, delirium, Tourette syndrome, substance use disorder in dual diagnosis like Huntington's disease, ASD, impulse control disorder. Most important thing here is that you need to remember the odd one out. Odd one out, I mean to say like Huntington's disease, Tourette syndrome, borderline PD, PTSD, OCD, other than anxiety and depression, these are also used for these conditions. Adjunctive management of agitations, aggression, severe anxiety, severe sleep difficulties when sedative hypnotics are contraindicated. So when patient has severe sleep difficulties and hypnotics or sleeping medications are contraindicated, so you have to use these medications in case of agitations, aggressions, and anxiety. Onset, acute, rapid calming effect and decrease in agitation, antipsychotic effect with improvement in thought disorder, delusions, hallucinations may take 1 to 4 weeks. So, full effect will take 1 to 4 weeks for antipsychotic medications to work. No one can right away have effect from antipsychotics, okay? Rational uses, no reason to combine two or more antipsychotic, although this is quite common in clinical practice, so no need for combining antipsychotics, okay? All antipsychotics are equally effective except for clozapine. This is the question now, okay? So wherever there is exception, you need to know. So except for clozapine, all antipsychotics are equally effective. What is different about clozapine? Considered to be most effective in treatment-resistant schizophrenia. So any patient with treatment-resistant schizophrenia, think about clozapine now, okay? Atypical antipsychotics, second generation, are as effective as typical ones, first generation antipsychotics, and have different adverse effect profile. Main difference is lower risk of EPS and TD, tardive dyskinesia, but more metabolic side effects. So you need to know the first generation and second generation antipsychotics are different in terms of EPS, extrapyramidal symptoms, and metabolic side effects. One has more metabolic side effects, whereas the other one has more EPS symptoms, okay? Side effects. Choose a drug to which the patient has responded to in the past or that was used successfully in the family members. This is also another question, I would say. They may give you an exam. They would give you a case scenario where there was a previous family member who was treated with certain drugs and he or she was, was uh, his symptoms were well controlled with that certain medication. Now what medications are you going to give this patient? So consider, if there's no other additional information given, consider giving that particular medication to the same person because this has worked in the family member as well. So this is another question, okay? Route is peroral, short-acting, long-acting depot IM injection, sublingual. More recently, there is inhaled aloxapine, mainly used in the setting of acute agitation. If no response in 4 to 6 weeks, switch the drugs. Okay, so you have to give 1 to 4 to 6 weeks. If no effect, then switch the drug. And this is another question because they may give you a scenario where the patient is coming in now within 4 weeks. The patient says it's been a month and it's not working. You have to give 4 to 6 weeks, and after that you will think about maybe increasing the dose or switching the drug. Duration minimum 6 months and usually for life is in most patients with primary psychotic disorder, variable for others. So you have to at least give the medication for 6 months or lifetime. Okay, not less than that to any patient with in need of psychiatric medication. Okay, long acting preparations antipsychotic formulated in oils for IM injections received on an outpatient basis. Indications initially meant for individuals with schizophrenia and other chronic psychosis who relapse because of non adherence, but current initial evidence suggests that there are better than oral preparations overall. So IM oil based injections are better than oral preparation. Should have been exposed to oral forms prior to first injection. So you don't have to first directly go to injection form. You have to give oral first and see if it works. Well and good. If it doesn't work, then you have to go on injections. Dosing start a low dose, then titrate every 2 to 4 weeks to maximize safely and minimize side effects. So you have to start slowly, slow and low, and then you have to go up to 2 to 4 weeks, and after that you have to maintain a dosage where there is minimal side effects. Side effects similar to side effect profile of oral preparations of same drug. Now, Canadian guideline for treatment of acute psychosis in ER. Very important, you need to even know the dosage in this situation. Let's say haloperidol 5 milligram IM plus minus lorazepam 2 milligram IM. So injections in emergency cases. Let's say you have a patient coming in emergency who is in a psychiatric condition, like he's not behaving, he's not in his normal senses. So what you have to do is you have to give him injectable forms of and benzodiazepine, lorazepam or haloperidol. Haloperidol is 5 milligram IM and lorazepam is 2 milligram IM. Loxapine peroral or IM 25 milligram plus minus lorazepam 2 milligram IM. This is basically a question they will definitely ask you about antipsychotic medications or psychiatric management in ER settings as well. Olanzapine 2.5 to 10 milligram per oral IM oral quick dissolve. Its time to peak is the same as regular per oral 4 to 6 hours. Okay, so you have to give like 2.5 till 10 milligram max of olanzapine. Risperidone 2 milligram M-tab liquid. Okay, so medications used are haloperidol, lorazepam, loxapine, olanzapine, and risperidone. Write them down, learn them by heart. This is very important. Okay, moving on. So common antipsychotic agents. So now there is this name of list of medication. Let's just cover the boxes on the right side first. Dopamine pathway is affected by antipsychotic. So mesolimbic pathway, mesocortical pathway, nigrostriatal pathway, and tubero infundibular pathway. So you need to know which pathway is for what certain action. They may give you this information on QE1 as well. So you need to know it. Like mesolimbic is for emotions, reward. Mesocortical is for cognition, executive functions. Nigrostriatal is for movement. Tuberoinfundibular is for prolactin hormone release. Okay, and then associated pathology is mesolimbic. High dopamine causes positive symptoms of schizophrenia. Low dopamine causes negative symptoms of schizophrenia from mesocortical area. Nigrostriatal is low dopamine causes EPS, and tuberoinfundibular causes low dopamine causes hyperprolactinemia. So you need to know this as well. Okay, this is important. Now, typical first generation versus atypical second generation antipsychotics. So typical ones are first generation and the atypical ones are second generation. What is the mechanism? It blocks postsynaptic dopamine D2 receptors. So typical ones blocks the D2 receptor, atypical ones blocks dopamine receptor, blocks serotonin receptor, 5H2 receptors in the presynaptic terminals, and trigger dopamine release and reversing dopamine blockade in SWAMP pathway. Some are partial D2 receptor agonists. So what is the difference is the typical ones block postsynaptic dopamine receptors, but the atypical ones slightly block and then they release and then they block the presynaptic ones as well, and also along with dopamine receptor they also block the serotonin receptor. So in the typical ones, the pros are inexpensive, plenty of injectable forms available in typical ones. Atypical ones has EPS less prevalent, low risk of low risk, and then mood stabilizing effect is the pro of atypical ones. But cons are that typical ones have more extrapyramidal side effects, okay, like tardive syndrome, long term, okay, and they are not mood stabilizing. Whereas this atypical one, they are more expensive, and they have less injectable options available, and they have more side effects related to metabolic problems like obesity, diabetes, weight gain, hypertriglyceridemia, or hyperglycemia, okay. So metabolic problems are associated with atypicals one, exacerbation of new onset of obsessive behavior. Now coming to anticholinergic effects. So if the patient has an anticholinergic effect, the patient would go red, hot, dry, and blind, and mad. Like he'll be mad, he'll have vision problem, he'll be, angry, all those kind of symptoms. Okay, now coming to the common antipsychotic agents. So first table is for typical ones, the typical antipsychotic which has more EPS side effects, whereas the second generation has more metabolic side effects. So those are called atypical ones. Let's start with typical ones. So typical one is haloperidol and flufenazine, and then there is another one called zuclopenthixol. So you don't really need to know zuclopenthixol, but you can memorize if you can. That's gonna be helpful. Perfenazine, loxapine, and chlorpromazine. Okay, so at times they may give you vague names of these medications, so it's good to know all the names at least, and then the common ones you can know the side effects for them. Okay, and then moving to atypicals in order of potency from high to low. So they are basically in potency, in terms of potency they are high to low. That means the ones on the top are the most more potent drugs. That's why they are mostly used in emergency situations like haloperidol. Now going to atypical one, risperidone. Risperidone for IM, long acting preparation, and then paliperidone, and then there is another one called olanzapine, and Isonapine, ziprasidone, ariprazole, quetiapine, and clozapine. Okay, these are the one. Clozapine was the one that we were using for treatment resistant schizophrenia. Okay, so these are just mainly in the name, so you don't really have to go through the dosage so far. Just remember the dosage for emergency treatment of psychosis. Okay, now on the right side it says metabolic and cardiovascular adverse effect associated with antipsychotic drugs. All atypical antipsychotic can cause cardiovascular metabolic side effects such as obesity, dyslipidemia, hyperglycemia, weight gain. Olanzapine, dozapine are most likely to cause these side adverse effects. The mechanism that underlies the metabolic cardiovascular is not fully understood. However, histamine, dopamine, serotonin, and muscarinic receptor are implicated. Now, in this statement, if you see, it says olanzapine and dozapine are most likely to cause adverse effects. So remember, atypical ones are olanzapine and dozapine and all those risperidone and stuff, right? Olanzapine is the most common one to cause obesity and metabolic side effects. O for olanzapine, O for obesity. That's how I remember it. Okay, so that's a tip because this is usually asked in the exam as well. And dozapine as well is also associated with more cardiovascular and metabolic side effects. Now, another important question is QTC prolongation is an important adverse effect of all antipsychotic. Although not required, consider getting ECG prior and after initiating new medications and monitor QTC. Typical ones are chlorpromazine, haloperidol, warrant systematic baseline and follow-up ECG. Atypical one are ziprasidone has the highest risk among atypical ones. Clozapine also warrants systematic baseline and follow-up ECG. Very, very important paragraph. I would say anyone who's doing QE1 learn these things by heart. QTC prolongation is caused by which medications? In typical ones, in atypical one, you need to know this. This is I can't emphasize more on the statement like you need to know chlorpromazine, haloperidol, you need to warrant ECG. This is a very important question. Atypical ziprasidone has the highest risk among atypicals. Clozapine also warrants systematic baseline follow-up ECG. So you have to do ECG in patients with on antipsychotic. In typicals one, you have to do especially for the patients on chlorpromazine and haloperidol. In atypicals one, you have to do it for ziprasidone as the highest risk among atypical. What is the risk? Risk of QTC prolongation. Okay. Now, features of neuroleptic malignant syndrome. Another very, very important concept that they want you to know is the difference between neuroleptic malignant syndrome and serotonin syndrome. So, how would you differentiate? In patients with serotonin syndrome, they will have twitching, they will have shivering, restlessness, flush, sweaty, and they'll be having vomiting, diarrhea, abdominal pain, GI symptoms. They have GI symptoms, whereas neuroleptic malignant does not have GI symptoms, whereas they have severe global rigidity and pilar. Okay, NMS has pilar and rigidity, whereas serotonin syndrome do have GI symptoms. Okay, fever, autonomic changes, increase heart rate, blood pressure, sweating, rigidity of muscles, mental status, confusion. Farm symptoms are also seen in serotonin syndrome. SS can be distinguished from NMS by the following. So you need to know how to differentiate it. Okay, moving forward, commonly used atypical antipsychotic. Okay, so moving forward, now what are the names? This is also a very important table. Why? I'll tell you guys as soon as we start reading it. Now, what are the advantages? Risperidone was an atypical antipsychotic, which was the most potent one. So lower incidence of EPS than typical antipsychotics at lower dose, less than 8 milligram, associated with less weight gain compared to olanzapine and clozapine. So risperidone is a good drug of choice. Has low APS side effects, but has also low GI side effects, like which are more associated with olanzapine and clozapine. Highest risk of EPS disadvantage, highest risk of EPS TD among small for gestational age. Avoid if high risk of EPS or existing movement disorder, elderly, elevated prolactin, sexual dysfunction, galactoria, gynecomastia, menstrual disturbance, infertility. Very important. I know it is really overwhelming to learn these nitty gritties and these tiny, miny details, but trust me, these are the ones that they want you to know, because that would make you stand out and pass the exam easily. They would not ask you, like, what test to do for anemia. No, they would ask you these details because these are the tough to remember, right? So you have to avoid risperidone in patients with SGA, small for gestational age. Avoid high risk of movement disorder like elevated prolactin levels, or have sexual dysfunctions, or have galactoria, gynecomastia, menstrual disturbance, infertility. So in these patients, you have to give risperidone. You have to avoid risperidone. Sorry. And then comment is quick dissolve, MTABs, and long acting consta. Okay, not important for you. Now moving to olanzapine, better overall efficacy compared with haloperidol, well tolerated, low incidence of EPS and TD. Problem is weight gain, metabolic effects, avoiding. So you have to avoid olanzapine in patients who are diabetics because it causes metabolic problems. Sedating, avoid if high risk of falls and fracture. So you have to avoid olanzapine in two patients, one in diabetic and the other one is high risk of fracture or falls. Okay, so make notes of these conditions. Quick dissolve formulations used commonly in ER for better compliance. Acute IM form available. Not for you. Quetiapine associated with slight weight gain compared with clozapine and olanzapine, but more than the other atypical mood stabilizers. So make a list in terms of the most common one that causes weight gain, metabolic problems is olanzapine, then clozapine, then quetiapine. Okay. Okay, so you don't have to use it in sedating and orthostatic hypotension. Avoid if high risk of falls and fracture, QT prolongation, high doses, caution if cardiac risk. So this cardiac risk or QT prolongation, you don't have to use quetiapine. Excuse me. So and similarly, like olanzapine, you don't have to use quetiapine in patients with high risk of fracture and falls. Now coming to clozapine. Clozapine is most effective for treatment-resistant schizophrenia. We have been reading this statement for the third time now, so you should remember it by now. Okay, treatment-resistant schizophrenia, clozapine does not worsen tardive symptoms. May treat them. Approximately 50% of patient benefit, especially paranoid patients and those with onset after 20 years. Okay. Weight gain and metabolic effects. Avoid diabetes mellitus, sedating, orthostatic hypotension. Avoid if high risk of falls. So this is the third drug that you have to avoid in patients with falls. First was olanzapine, then quetiapine, and then clozapine. Potentially severe constipation. Avoid if risk of fecal impaction. So it may cause you constipation as well and bowel perforation. So clozapine has some GI effects as well. Cardiomyopathy, caution if existing heart disease, reduce seizure threshold, caution if seizure disorder, agranulocytosis, avoid in existing leukopenia, neutropenia, and require ongoing CBC monitoring. This is a very important question. They may ask you about what test you have to repeat if the patient is on clozapine. You have to do CBC after a few weeks. Why? Because it may cause you agranulocytosis. It may cause you to have seizures, obesity, diabetes, orthostatic hypotension, agranulocytosis, seizures, constipation, bowel perforation. So clozapine has got a lot of side effects. So be mindful of that as well. Okay. So now it says weekly blood counts for 6 months, then 2 weeks, and do not use with other drugs that may cause bone marrow suppression due to risk of agranulocytosis. So clozapine has a serious side effects of agranulocytosis. First, you have to do CBC every week, and then you have to after 6 months you will do it bi-weekly. Aripiprazole, less weight gain and risk of metabolic syndrome compared to olanzapine, and lower incidence of EPS compared to haloperidol. Mood stabilizing, and the disadvantages insomnia, akathisia. So aripiprazole causes A for aripiprazole, A for akathisia. Okay. Clozapine, you have to do ECG, you have to do screening for constipation, for bowel perforation, for cardiomyopathy, you have to repeat CBC for agranulocytosis, weight gain, a lot of problem with clozapine. But this is the most effective drug for treatment resistant schizophrenia, and even we can use it in paranoid patients. Okay, so that's that. Now coming to, so now even in the notes they say risk of weight gain, clozapine has most, then olanzapine, then quetiapine, then risperidone. Okay, so you can learn this by heart. All the things that I've mentioned here in this table, a lot of questions from there on QE1 exam. Okay, so make sure you learn them by heart. Now coming to side effects of antipsychotics. What are the side effects? Anticholinergics, dry mouth, urinary retention, constipation, blurred vision, confusional state, vision problem. Okay, so anticholinergic means dry mouth, no water in the mouth, the urine is retaining, the poop is retaining in the body, constipation, blurred vision, confusion state. So anticholinergic means everything is retaining in the body, your mouth is dry. Alpha adrenergic blockade, orthostatic hypotension, erectile dysfunction, failure to ejaculate. Dopaminergic blockade is extrapyramidal symptoms, galactoria, amenorrhea, erectile dysfunction, and weight gain. Antihistamine may cause side effects like weight gain and sedation. Hematological agranulocytosis with clozapine, especially hypersensitivity reaction like liver dysfunction, blood dyskaryosis, skin reaction, neuroleptic malignant syndrome, altered temperature regulation, hypothermia or hyperthermia. And then endocrine metabolic syndrome, cardiac is QT prolongation. Very important aspect of QE1 is neuroleptic malignant syndrome. Okay, and you need to really know how to differentiate it with serotonin syndrome. Is that serotonin syndrome has GI symptoms, whereas neuroleptic does not have GI symptoms. It is mostly rigidity. Okay, so psychiatric emergency, it is a psychiatric emergency. Hypothesis is due to strong dopamine blockade, increased incidence of hypotension, and depot antipsychotics. Risk factors is medication factor like sudden increase in dosage, starting a new drug. Patient factor, medical illness, dehydration, exhaustion, poor nutrition, external heat load, male, young adults. So after starting a new medication, patient is more prone to have neuroleptic malignant syndrome. Clinical feature, how would the patient present? Mental status change usually occur first. Fever, rigidity, autonomic instability develops over 24 to 72 hours. Increased creatinine phosphokinase, leukocytosis, and myoglobinuria. There will be some red cells in urine, leukocytosis, high WBC count, and there will the creatinine phosphokinase will be elevated. That means the muscle is wasting. Okay, now coming to the treatment, how would you treat it? Discontinue antipsychotic drug, definitely, because that is the one that is causing it, right? You have to hydrate the patient, give them fluids, cooling blankets. Dentroline is the treatment. Hydantoin derivatives used as a muscle relaxant, and bromocriptine, dopamine agonist. So dopamine agonist is bromocriptine, dentroline, hydration, and cooling blankets. Okay. Moving on to extrapyramidal symptoms, incidents related to increased dose and potency. Acute is early onset, reversible, and tardive is late and often irreversible. So extrapyramidal symptoms we have already studied is caused by the first generation antipsychotic medication, right? So what are the extrapyramidal symptoms? Early on or later on? Early on are the ones that are reversible, and then later on are the ones which are irreversible. So let's start with acute or tardive. There are four different kind of symptoms. One is dystonia, akathisia, parkinsonism, and dyskinesia. So dystonia is causes both acute or tardive. It could be acute or tardive. High risk group is acute young Asian or black males. Sustained abnormal posture, torsion, twisting, contraction of the muscles, group of muscle spasm, oculogyric crisis, elengospasm, and torticollis. Whereas the onset is within the 5 days, and tardive it's more than 90 days. What is the treatment of dystonia? Is benztropine, and diphenhydramine usually intramuscular. So benztropine or diphenhydramine is a treatment for dystonia. Okay, so you need to know the presentation, how it would present, and what is the treatment. Then comes akathisia, which is acute or tardive and mostly in older females. And other than dystonia, mostly all three of them are caused in older patients, whereas akathisia and Parkinsonism is in older females, whereas dyskinesia is in older patients. Now, in akathisia, motor restlessness, crawling sensation in the legs relieved by walking, very distressing, increased risk of suicide, and poor adherence. The patient is restless. They have this crawling sensation in the legs. They're walking. They're constantly, they're not comfortable. Okay, acute within 10 days, tardive more than 90 days. Treatment is acute. You'll giving lorazepam, propranolol, benztropine, diphenhydramine. Best approach: reduce dose or change antipsychotic to lower potency. So you need to know what are you gonna do. First, you will treat the patient with lorazepam. You'll give propranolol, benztropine, diphenhydramine. But then the best approach is to reduce the dose or change antipsychotic to lower potency. Then Parkinsonism is acute in older females, and tremors, rigidity, cogwheel akinesia, postural instability, decrease, absent arm swing, stoop posture, shuffling gait, difficulty pivoting, acute within 30 days. And the treatment is benztropine, reduce dosage, and change antipsychotic to low dose atypical antipsychotic. Dyskinesia is tardive in older patients, and purposeless involuntary constant move that involves facial mouth musculature, less commonly limbs the limbs, rarely the diaphragm, hiccups, and the tardive is more than 90 days. So duration is 5 days, 10 days, 30 days, and more than 90 days. Tardive, no good treatment, may try clozapine, discontinue drug, reduce dosage. Recently the FDA approved ovelbenazine and deuterbenzine for treatment of tardive dyskinesia. So tardive dyskinesia is usually caused after more than 90 days. Parkinsonism for 30 days, within 30 days, akathisia within 10 to 90 days, and dystonia for 5 to 90 days. So, but usually dystonia is caused in young patients, whereas akathisia, Parkinsonism, dyskinesia is caused in older patients. And each and every symptom side effects has its own presentation. Dystonia is mostly in the muscle of eyes, face, and shoulders, and torticollis in the neck. Akathisia is mostly in the leg, walking problems. Parkinsonism is mostly in the arms or in the gait difficulty, okay, and rigidity. And dyskinesia is mostly in the face, in the limbs, in the diaphragm, all those things, okay. Moving on to the anticholinergic agents. Typically benztropine 2 milligrams per oral IM, IV once daily, or diphenhydramine 25 to 50 per oral IM. Do not routinely prescribe with antipsychotics. Give anticholinergic agents only if high risk of acute EPS or if acute EPS develop. Do not give these for tardive symptoms because they may worsen the condition. So you don't have to give anticholinergics with all your antipsychotics. Only have to give once the patient establishes EPS symptoms, and then you don't have to give anticholinergics with tardive symptoms. For tardive, they said the treatment is valbenazine or deuterbenzine, or you may also try clozapine, but you don't have to give anticholinergics like benztropine or diphenhydramine like you were giving in dystonia, akathisia, okay, and also in Parkinsonism, right? But in akathisia, you see, you have other options like propranolol, diphenhydramine, lorazepam, benztropine. Now, so that finishes up with antipsychotic. I hope I have not left any boxes here. Yeah, we have done. So this is a very important topic, and I'm sure like if you're going to give QE1, I trust me, almost 10 to 15 questions will be answered just from these 2 to 3 pages from Toronto notes. So make sure you do it. If you want, I can make further videos on rest of the medications as well, but I believe this was the most important one, so I had to do this one. Let me know if there's any specific topic you want me to cover, and I hope you liked today's video. Good luck for your exams. Thank you so much.